Hi everyone, I'm here to share a research study that related to my future profession. The title of this research is The Board Scale as an Important Tool of Self-Monitoring and Self-Regulation of Exercise Prescription in Heart Failure Patients and During Hydrotherapy Randomized Blinded Control Trial. The aim of the study was to evaluate if the board scale could be used to self-monitor and self-regulate exercise on land or in water by maintaining the heart failure patient's heart rate between the anaerobic threshold and respiratory compensation point in the exercise training zone. The summary or discussion of this study. The main finding of the study is that exercise training guided by the board scale of between relatively easy and slightly tiring took the patient's heart rate into the zone between the anaerobic threshold and respiratory compensation point during land or water exercises. The exercise performed on land took the heart rate nearer to the respiratory compensation point when compared with the water group. Aerobic exercises training is a well-established non-pharmacological treatment for patients with heart failure. Hydrotherapy is a new and well-tolerated method of exercise rehabilitation that was first proposed as alternative for elderly and impaired patients with heart failure, but which showed important improvements is neurohormonal attenuation because of the hydrostatic pressure and warming. Independent of the method exercise rehabilitation, the prescription of adequate aerobic efforts is crucial to obtain both acceptable training stimulus and reasonable control of the exercise-related risk. Despite there being no consensus about which exercise intensity is the best for heart failure patients, a submaximal level between the anaerobic threshold and respiratory compensation points seems to have the best security efficacy relationship. The heart rate is a good tool to use as a guide for exercise training because of the close relation with the oxygen consumption, especially with the considering a percentage of heart rate reserve in a heart failure patient on optimized carvedilol therapy. In our study, the land and water exercises were well tolerated without any complications such as dizziness, breathlessness, or muscular pain. The high rate of dropout from exercise program may be attributed in the part to the poor ability of most individuals to accurately self-monitor and self-regulate their exercise intensity. The board scale is a simple and cheap method of self-monitoring that correlates with submaximal effort in healthy subjects. The transition from aerobic to anaerobic metabolism is associated with exponential changes in several perceptible peripheral physiological functions such as ventilation. Heart failure patient can manage to use Bird scale well, and its use guarantees a submaximal effort in the 6-min walking test. The board scale also can be quite useful in prescribing exercise training intensity. In the present study, the patient did not have any difficulties understanding the exercise training as guided by the board scale. Some studies have evaluated perceived exertion and transition to anaerobic metabolism during exercise training. Ikikakis et al. Studied 30 young and healthy volunteers on a treadmill and concluded that exercise intensity above the point of transition from aerobic to anaerobic metabolism is accompanied by significant displeasure about the exercise. Hitler et al. Studied 29 untrained male subjects using a circle ergometer and treadmill and concluded that the exercise modality does not affect the perception of exertion of anaerobic threshold. Hill et al. Determined that effect of exercise training on perceived exertion at the respiratory compensation point and concluded that the rating of perceived exertion is not affected by training despite the fact that after exercise training, the respiratory compensation point occurs at a higher work rate. It seems that in a healthy subject, self-perceived exertion is related to the metabolic profile, but this relationship is unknown in heart failure patients. In our study, almost all the heart failure patients in both groups had an exercise training heart rate between the anaerobic threshold and respiratory compensation point when guided by the board scale of between relatively easy and slightly tiring. Our data are partially in agreement with the statement from the American Heart Association Committee on Exercise, Rehabilitation, and Prevention, which recognizes that the ventilatory or anaerobic threshold generally occurs at a rate of perceived exertion between 13 and 15 on the board scale. The land group had an exercise training heart rate near the respiratory compensation point, 95%, than did the water group, 86%, for the same perceived exertion between relatively easy and slightly tiring on the board scale. This finding was also true in relation to the peak heart rate by the CPET, 85 to 78% respectively. The respiratory compensation point typically occurs at 90% of the peak heart rate. The lower heart rate in the water exercise group could be explained by the improvement in cardiac function and attenuation of neurohormonal system and vasodilation promoted by the warm water. Achievement of age-predicted values for maximal heart rate during exercise is often used as a reflection of maximal or near maximal effort, 220 minus age. This method has been questioned by some authors, but it is currently the most commonly used method worldwide. Carvalho et al. Found a peak heart rate of 65% of the maximum age minus predicted heart rate in an optimized heart failure group. Heart rate between 50 and 60 beats per minute and carvedilol dose. Mizani et al. Observed a peak heart rate of 76% of the maximum age predicted in heart failure patient with non-optimized B-block dose. These data are in agreement with ours. In our study, the percent EHR minus predicted was 61% for the land and 58% for the water exercise groups, which indicates that the board scale was useful for ensuring submaximal exercise training in the present heart failure patients. In our study, the difference in the percent EHR minus peak during water immersion has been shown previously. Interestingly, the water group in the present study seemed to exercise at a lower heart rate. Despite a similar perceived level of exertion in both groups, maybe the hydrotherapy has a protective effect on the heart that is more pronounced than with the land exercise. This aspect should be followed in further studies, especially looking at the training effect of the longer training period. Methods and results of this study. Patient perform a cardiopulmonary exercise test to determine their anaerobic threshold respiratory compensation points. The percentage of the mean heart rate during the exercise session in relation to the anaerobic threshold heart rate, percent EHR minus 80 in relation to respiratory compensation point, percent EHR minus RCP in relation to the peak heart rate by the exercise test, percent EHR minus peak and in relation to the maximum predicted heart rate, percent EHR minus predicted was calculated. Next, patients were randomized into the land or water exercise group. One blinded investigators instructed the patient in each group to exercise at a level between relatively easy and slightly tiring. The mean heart rate throughout the 30 minutes exercise session was recorded. The percent EHR minus 80 and percent EHR minus predicted did not differ between the land and water exercise groups, but they differed in the percent EHR minus RCP and 95 plus 7 to 86 plus 7 is equals to negative 1, and in the percent EHR peak 85 plus 8 to 78 plus 9 is equals to 7. Conclusion. The word scale of between relatively easy and slightly tiring was an important tool for self-monitoring and self-regulating exercise prescription in land and water exercises by maintaining the heart failure patients' heart rates between the anaerobic threshold respiratory compensation point in the exercise training zone. Land exercises took the heart rate closer to the respiratory compensation point when compared by hydrotherapy in rehabilitation programs. These data are potentially important to conducting and adopting exercise training prescription without a CPET, which implies lower cost.